better than mine. Any other questions for this abstract session? If not, we'll move right along. Thank you so much, Jamie.
Our next presenter is Sami Slimani. Her presentation title is Morphometric Study of Algerian Hips, an etiological study to explain the low prevalence of hip osteoarthritis in Algeria.
Thank you very much for your introduction. Good evening. I would like to thank the organizers for the opportunity to present our data. I'm Sami Slimani from the University of Patna and Algeria, and I present this work on behalf of my colleagues. The main purpose of this work is to evaluate the morphometric parameters of the Algerian hips in order to try to explain the low prevalence of hip osteoarthritis among Algerians. These are our disclosures. So, you know very well that OA is the most prevalent musculoskeletal condition, and you are very familiar with the distribution of OA according to the involved sites. And in Western populations, hip osteoarthritis is the second or the third most prevalent site of OA. Hip osteoarthritis it may be secondary to a combination of risk factors which were chronologically described as the presence of mild dysplasia, the acetabular protrusion, and more recently the femoroacetabular impingement. However, there exists an ethnic variation according to the populations concerning the relative frequency of different sites of osteoarthritis, with the hip osteoarthritis being very rare when we take an Asian or African populations as compared with Western populations. So to determine the cause, there was a work published in 2011 that tried to find out morphometric differences between Chinese and US hips that could explain these differences. You see very well that the ratio hip to knee OA is very low in Algeria, with a recent work that was published showing that there was only one hip osteoarthritis for every 27 knee osteoarthritis seen in an outpatient condition. The paper that has been published in 2011 found that dysplasia, although mild dysplasia was more prevalent among Chinese women, as shown here, that may be counterbalanced by the presence of overcoverage among the US female volunteers that may explain the rarity of hip osteoarthritis among Chinese. So the aim of our study was to proceed by realizing the same protocol, the same methodology, in order to compare normal hips, Algerian hips, with normal American hips. American hips were taken from the study of osteoporotic fractures, which is a very known cohort. So we proceeded with the same methods. We have collected 200 analysis of 200 hips among 100 Algerian female subjects aged 16 years and more. Pelvis radiographs were performed when there was an indication for that, especially low back pain, sciatalgia, and osteoporosis. There were 5 investigators coming from 5 centers, and each one had recruited 20 patients. We have excluded hip OA even when it was asymptomatic, so we have excluded every hip which presented with a Croft score of more than 1. All radiographs have been centralized and read by one operator at day 0, and then we had a subgroup of 20 radiographs that have been reread by the same operator at day 15 in order to calculate the intra-observer variability. And the same subgroup of radiographs had been interpreted by an independent reader in order to calculate the inter-observer variability. These are the different parameters that we have calculated, which were exactly the same that evaluated for during the publication of 2011. So to evaluate the femoral head coverage, we have employed two parameters, the center edge angle as described by Weiberg and the acetabular slope of Tunis. Retroversion was assessed by looking for the presence of the crossover sign. Femoral head asphericity was evaluated using two parameters, the impingement angle and the femoral head ratio as described by Murray. And the cutoffs for each measure the cutoffs were the largely used classical cutoffs employed in preceding papers for each abnormality such as dysplasia and femoral acetabular impingement, the pincer type and the cam type impingement. We have calculated the mean and the standard deviation for each angle and established proportions for every cutoff. And we have compared our results with the results from this study of osteoporosis fractures by calculating the t-tests for continuous variables and the z-test for proportions. So these are the results. We have obtained an excellent reproducibility with an ICC that ranged between 0.91 and 0.97. Our cohort consisted of 100 patients that were slightly but significantly younger than the Americans and which had also a higher BMI than the American cohort. In this table, in the upper part of this table, we see the mean values for each parameters that we have measured, and on the lower part of the table, you have the different cutoffs, applied cutoffs, with the significant results shown on bold characters. So, if we want to simplify, this table summarizes only the significant results. So we see that there are three main differences between the two populations. We have first noticed that there were no dysplasia seen on the Algerian hips when compared with the American hips that presented with a prevalence of 7% of mild dysplasia. The second abnormality was that 3/4 of the Algerian hips, female hips, had signs of impingement, of overcoverage, but this may be largely counterbalanced by the almost inexistence retroversion on the Algerian hips as compared with the very frequent retroversion observed on the American female hips. So our hypothesis is that the association of the absence of dysplasia and the almost absence of retroversion on Algerian hips may have explained the very low prevalence of primary hip OA in Algerians. Two main limitations to our study. First, the study included only women, and so we cannot generalize on the whole population. And the second limitation is that we have used only pelvic X-rays, so we have only indirect estimation of different abnormalities. But we were obliged to use these parameters because the major aim was to compare with the SOF cohort. So if we want to summarize all this, we can say that the rarity of hip osteoarthritis among Algerians may be explained by ethnic and differences in the shape of the hip joint. You have on the left a typical hip joint from the US SOF cohort, and on the right a typical Algerian joint from our cohort. So you notice that the first abnormality is the asphericity of the femoral head in Algerians as compared with the perfect shape of the femoral head in Americans. But another astonishing difference is the almost constant antiversion of the hip joints in Algerians that may have played a protective role versus a very prevalent retroversion Here we can notice the presence of the crossover sign, but also the presence of the projection of the ischial spine on the pelvis. So this may have explained the rarity of hip osteoarthritis among Algerians. But all these are indirect signs and need more confirmation using modern imaging modalities such as arthro-CT and arthro-MRI. I would like to thank all the participating patients, and also I would like to thank you for your patience for having attended the last presentation of the day. Thank you very much.
Thank you, Sammy. Open the floor for discussion or questions. Bart?
Hi, Bart Wise from UC Davis. Just so I understand, I mean, these are really huge differences that you're reporting here, so I don't think it's really going to affect the outcomes. But just so I understand how you did this, did the same people who did the measurements on the Algerian x-rays also do them on the soft x-rays, or were you taking, or was it a whole different set of people who were evaluating the soft x-rays?
Unfortunately, it was not possible for us to make this measure for both cohorts because we were unable to obtain the original, raw data or the original radiographs from the original paper, because we have emailed the authors and received no answer. So we
they
only
should have answered you. Sorry.
Thank you.
Thank you.
Just, I guess, a follow-on question from that. The prevalence of retroversion amongst the Caucasian, well, the US hips seems astronomically high.
Yeah.
Has that been reported in previous publications?
Yeah, it has been reported on the 2011 publication, and also it has been reported a even higher prevalence among the Chinese, with a roughly 90% prevalence of retroversion. So it was astonishingly high.
Yeah.
All right, I have a quick question about the cause of it. I'm just curious, because Algerians, Americans might have different lifestyle. So people in Asian countries or African countries might be sitting more on the floor or squatting more than the American counterparts. So I wonder, in the developmental years, maybe the deep squat and deep hip flexion kind of change the acetabulum shape or orientation. Do you have any comments on that?
Yeah, to date we cannot distinguish, we cannot be sure that these abnormalities observed in adults may be due to congenital genetic inheritance factors or to developmental factors. Mm-hmm. There's no study that had tried to find out if it's more due to ethnic and genetic factors or to lifestyle factors. Okay. Unfortunately, there's no work in this field.
All right, thank you.
Thank you.
Any other questions? All right, so we're done with this session. Thank you for all the presenters and audience for a wonderful session. I hope you have a good rest of the meeting.